Hello friends, today we are going to talk on diagnosis of asthma in preschool age. What is preschool age? Preschool age means less than 5 years. I think everybody will agree asthma should be diagnosed as early as possible. Just a few facts about the asthma. Asthma is a single disease. It affects 300 million people worldwide. It not only affects children as well as adults. It is one disease that affects both the children and adults. It is considered to be most common chronic disease in children. And sometimes before we thought it is a spastic bronchospastic disease. Today we view asthma as an inflammatory disease, and it is characterized by episodic bronchial constriction, and that is the reason why many people say that even though gene environment interactions plays a major role in asthma, you cannot change the gene component, but by avoiding triggers we can make a child or an adult have a near normal life. Asthma is a one disease that either underdiagnosed or overdiagnosed, but in children, particularly in preschool age, it is underdiagnosed. Before starting my lecture, I do want to ask one thing. Does asthma occur in preschool age? I give five seconds. What is your answer? You tell by yourself. Now the answer I give that it is not my answer. These are all published in literatures. Scientific papers say that 50 to 80% of children who have asthma develop their symptoms before 5th birthday. And another one says that 75% of children with a persistent asthma started, these are all appeared little several years before. And another one I can say that recurrent wheeze frequently precedes the diagnosed asthma in more than 20% of infants. Now you all agree that asthma is the one that happen even below 5 years. Another question is, can you make a firm diagnosis of asthma in children under 5? Actually, this question I asked in many forums. Many people say no, some people will say. Now what is the answer? All the guidelines, either a GINA, ERS Task Force or Indian Academy of Pediatrics, all these guidelines stress the difficulties in making firm diagnosis of asthma in children under 5 years. So it is not a very easy job. We have to approach the child. If you methodically follow the child, or if you methodically approach the condition, we can diagnose asthma even less than 5 years and all. GINA approaches asthma in 3 groups. Group 1, 2, 3. Group 1 is the one that tells about children below 5 years. Actually, this approach of GINA is very good because in group 3 and 2, we can easily make a diagnosis of asthma. But in group 1, it is very difficult. And even GINA says find difficult. But it helps us how to make a diagnosis. And all we are going to discuss this in later slides. What are the conditions that produce wheeze below 5 years? These are the conditions. I do not enumerate. You all know that, starting from viral infection, gastroesophageal reflux, airway anomalies, foreign body, all these conditions, including cystic fibrosis, they do produce a wheeze. So I jokingly in my lectures say how we can fish asthma fish in a pool of preschool wheeze fishes. Is it possible? The answer probably after my lecture, in the end of lecture, you can very well confidently fish asthma fish. Coming to the wheezing in children, We can broadly approach V's below 5 years or V's above 6 years. If anybody asks, if anybody gets recurrent V's above 6 years, the most common cause is asthma, and we have to rule out. There, your spirometry helps a lot, and we can easily diagnose it. And we can add we can have document the diagnosis with PFT and particularly the spirometry and peak flow meters and all. That is what Gina says. But below 5 years, the commonest cause of this is viral infection. I think this you have to understand. So if you make a very fast diagnosis of asthma in below 5 years, probably you may err or you may make a wrong diagnosis also. Coming to the viral infections, I said below 5 years, the viral infections plays a major role. These viruses, starting from RSV, rhino, influenza, adena, including coronavirus, plays a major role. Actually, each virus has large number of serotypes. If one virus infection occurs today, that doesn't confirm immunity for a long time. So that is the reason why children are succumb to or children get the infection very frequently. When one child get viral infection in a class, it easily transmits the viral infection to the other child, and the cycle goes. That is the reason why the parent says that everything because of the school. When you go to the school, you catch up the cold, and sometimes it may end up in wheeze and all. Of all the viruses, RSV and rhinoviruses are very, very important because actually there are a lot of scientific studies conducted. They found that these two viral infections do interact with atopic status. You all know atopy itself is a talk to be discussed, we'll do later. And what they say, there are two assumptions regarding the viral infection and the atopic status. It is not fully clear whether early viral infections causes some cases of asthma to manifest, or whether subjects destined to suffer from asthma probably is going to asthma in the later years, but they started presenting with the symptoms very early when they are provoked by RSV infection. This is a $1 million question. We don't know. Still research is going on. That is the reason why if you don't want, see some family, they have a large predisposition to develop wheeze. So they necessarily should avoid viral infection. I am not telling avoiding the viral infection is very difficult, but still they should have this background knowledge. Once they, I think at least how to treat the viral infection is also very important. Coming to the phenotypes, what is phenotype? Phenotype is a cluster of associated features. Actually, understanding that helps in the management. For example, asthma itself is considered as many phenotypes. The most important phenotype is atopic asthma, non-atopic asthma, that is allergen-induced asthma, non-allergen-induced asthma, exercise-induced asthma, obesity-related asthma. Actually, these are all very, very important. For example, obesity-related asthma is a big subject because they have a, they do not, they annually suffer from neutrophilic inflammation. There, their response to ICS is little less. So all this phenotypic approach is very important. I am not going to the, we'll talk something later. And what I want to say that there are a lot of epidemiological studies have been conducted, not only in world and spots, but particularly in US. The most important study is a US cohort study. Okay. Actually, they followed a large number of children, and in below 5 years, they are able to identify 3 types of wheezing. That is a transient wheeze, non-atopic wheeze, IgA associated wheeze. Actually, transient wheezes is a large number of groups. Actually, they become all right. They start below 3 years and they end, and the wheeze stops below 3 years. Whereas in non-atopic wheezes also they start early, but they also slightly increase, but after some time that also come down. But only people with Ig associated or people with atopic tendency, when they develop wheeze, they continue to be long. I think this still holds good. And I think, but even though this observation is very good, it is not help in the management point of view. Actually, we are not going to give any concrete solutions for the practitioners. That is the reason why for last few decades, many people started using many things, many language. Some people, when the wheeze occurs in below 5 years, they call it as a rheumatic airway disease or viral induced wheezing or wheeze associated viral infection or wheezy bronchitis. I think all these, if you see the prescription, still you can see many of them are using this, but I think this has to be discouraged because it doesn't, it's not going to help anyway to understand better, and it will complicate the research of asthma. That is the reason why we have, I think in later slides, I will give you a correct answer for this also. So when we are all confused, the ARS task force come to rescue. Actually, I really, when this appear in the journal, I am the first person who really very happy because the ARS task force proposed a symptom-based phenotypic patterns. Actually, in a preschool whiz, there are many cohorts studies showed that many type of phenotypes, but the ERS task force says that we can approach preschool whiz as a episodic viral whiz and multiple trigger whiz. Actually, this is very useful in day-to-day management of asthma. I think still even today I follow this. And why I am telling is, what is this episodic viral wheeze? If you simply say that episodic viral is a very simple disease, this wheeze going to be disappear in no time after some few months and all. Whereas multiple trigger wheeze is the one that continue for a long time. So as the name suggests, episodic viral is, here the wheezing episodes are caused by the viral infection, but in between the child is totally normal in between the episodes. That is what episode, you can name it. See, some children, these are the children, we do have viral wheeze, but most of them they get disappear by 6 years. Coming to the multiple trigger wheeze, actually they doesn't stop with wheezing after viral URI, but they do start wheeze after activity, cry, laugh. If you ask the mother says, yes doctor, even if he runs, he get a wheeze. Even if he laugh, he get a wheeze. That is what the answer you get from the mother. If such a situation is there, then we have to follow these children very closely. And again, they, unlike the episodic viral wheeze, they may not be asymptomatic between the episodes. They often remain symptomatic. See, for example, mother says, whenever he catches a cold, my other child, within 7 to 10 days, it will become all right. But this child, the cold continues for a long time, even 2 to 3 weeks and all. That is the answer we get from the mother. And if you still go there, some of them say there is a personal or family history of atopy. Atopy is a separate, I say that some atopic diseases, they either may, personal atopy mean the same child would have suffered eczema in the earlier months or food allergy and all, or even the family members might suffer this and all. So atopy is a predisposition to respond immunologically with IgE response. I think it's a great subject. I think world is now going in this direction, and we are successfully control infections, but we are not able to control allergy. See, that is the reason why that hygiene hypothesis says that infection and allergy are on both sides of both sides. Once get controlled, the other may increase also. So you have to know last. I think these are the things we have to talk in a separate podcast and all. Coming to the GINA, even though it agreed with ERS, it also suggested some more simpler form. Why not to call the GINA advises, please follow each episode carefully. Episode means a child may have a wheezing or coughing or breathing difficulty. See, unlike the adult, in children, even recurrent cough also is equivalent to wheezing. That's what the teaching. So either they may have a wheeze or they may have a recurrent cough and we have to closely follow these episodes. And if these episodes are less than 10 days or more than 10 days, or if the number of episodes less than 3 or more than 3, or if the wheeze or cough occurs associated with the activity, particularly running, laughing, all these things are all very important, or even after tobacco smoke that have a wheeze for a long time and all. This also appear to be very simple. But Gina says that you put them in a slot, you write in the corner of your prescription whether they belong to the simple group or severe group. Okay, the simple group means the symptoms of cough and wheeze last less than 10 days, whereas in this end, the symptoms of cough or wheeze last more than 10 days. Every episode will exceed more than 10 days. Hardly this group, that is and the left side group, 2 to 3 episodes only will appear. After that, it become normal. But in this side, they say, no, every month I am going to a doctor, and every month we are getting nebulization. That all the answer you can get from that. So these are the group. Actually, these children that they may not have any symptoms in between. They were near normal. But unlike this group, right side group, actually they continue to have in between the episodes also some problem. And if you go into the history, they may have, most of the members may suffer from atopy. Actually, this is more or less the same thing. Why I am telling is, if you go like that, Gina says in this left side group, only few will have asthma, but in the right side group, most of the people will go for asthma. Actually, I simply compare the first slot. This slot can be compared with the episodic viral wheeze, and this slot can be compared with the multi-trigger wheeze. Actually, everybody agrees that the symptom pattern also change. Sometimes they will go from here to multi, or sometimes multi-trigger wheeze you may put. After some time, they slowly reverts back to this side also. So you should know how to follow the child. Then how to make a diagnosis of asthma. Actually, what many people say is that give a therapeutic trial. Therapeutic trial answer were, actually there are some conditions we should not do therapeutic trial. Can you tell me one thing? In tuberculosis, we should not do therapeutic trial. Okay, that is wrong. In tuberculosis, you have to have a molecular diagnosis. Then once you molecular diagnosis, if your diagnosis is made, then you start treatment. But asthma is something is different. Here, giving ICs itself give some solution. What is this therapeutic trial? So if you strongly believe particular child is having a recurrent wheeze, recurrent cough, every episode more than 10 days, and every month they are getting problem and all, you are already put in the slot of multi-trigger wheeze, put the child on budesonide, 200 micrograms daily, either through the spacer, actually you can see the picture, and you can observe after 8 weeks. And after 8 weeks, if the mother comes and says, yes doctor, my child is now quite all right, previously used to get every week problem and all, now last 2 months there is no problem, then you can stop the treatment, because a single trial sometime may not be answer. You stop the treatment, some children may become normal, some children after stopping the treatment they get back their symptoms, so you make a one more trial. So like that, if you can easily confirm asthma with a therapeutic trial. Once asthma is confirmed, then you can follow the management of Gina. Gina says that how to manage 5-year child developing asthma. Actually, this is a different topics we'll talk. Very simply, these children should be put on low dose inhaled corticosteroids as a controller, and it all depend upon step 1, step 2, 3, either low dose, medium dose or high dose, and you can also use as needed beta agonist as a reliever. That is once you make a diagnosis of asthma. Right. What are the hindrances? Actually, we are talking about the wheezing only, but many people will know, they may not know how to differentiate stridor, snoring and all. Actually, language is a real problem. When I happen to see a child from different parts of India, I always imitate. See, Wheezing means I always say that patient whether they like that such a thing is goes with the wheezing. But stridor is totally different. Stridor is something like that, like that. That sound will be there. Snoring, everybody knows, it usually appear in the sleep and all. Actually, when the language is a barrier, you can demonstrate these sounds so that the parents will easily answer. Coming to the differential diagnosis, it's not so simple. In below 5-year children, I already said recurrent viral infection, it's not so simple. They have other red flag signs also. They will have a severe gastroesophageal reflux, or in actually tracheomalacia and bronchomalacia is the one that has been widely talked, because any child below 1 year having recurrent wheeze but that is not responding to the asthma, that is ICS and all, you have to think of structural anomalies. Like that, you should be very familiar with that. And even cystic fibrosis also, and the child will presenting with some sort of a cough and wheeze and all. And if you put the direct question whether your child is having any loose, greasy, bulky stools, any mollussortic pattern, then sometimes you immediately get the answer. Even primary ciliary dyskinesia also start with the recurrent infections, recurrent cough, recurrent wheeze, and you can ask clinching diagnosis like chronic infections in the ear, or sometimes immunodeficiency also is one thing that happens. And any child with developing multifocal infection, you can strongly suspect this one all. You should know, even though we are making a diagnosis of asthma below 5 years, as a pulmonologist, it is our duty to rule out all the other red flag signs. Moreover, some children have comorbids also, not necessarily asthma alone. They do have other diseases. See, majority of the asthma children do have associated allergic rhinitis. At one point of time, they may come. One time they come for an asthma and wheeze. Other time they come with these symptoms: sneezing, running, blocked nose. You should know how, because every episode may not be asthma or wheezing. So you should know how to differentiate and all. Sometimes this being totally missed. Adenoidal hypertrophy means a child have blocked nose, and look at the face. Adenoid faces will be there. If you simply ask the mother whether how the child sleeps, yes, during his child, the child will make a very big sound and all. So you should know the comorbids, and you have to rule out these things, or at least you have to find out whether a particular child do suffer from the comorbids as depicted here. Finally, one question some people may ask: why asthma should be diagnosed early? This is because every attack of asthma do some damage. It not only injure the epithelial cells and smooth muscles hypertrophy or angiogenesis, that is new blood vessels and all formed and all. The most important thing is it will go for subepithelial fibrosis, that is called basement membrane thickening. Once a child started developing repeated attacks, then that airway remodeling sets in, and probably that will reduce the response to ICS and all. That is the reason why you cannot be, you don't say that I cannot diagnose asthma below 5 years. You can diagnose asthma, and that is what I have been telling, how to diagnose asthma in the very age. So finally, my simple, this picture that I showed you, how to fish, asthma fish in a preschool of fishes. I said most of the wheezes or coughing in preschool children are due to viral infection. That you should remember. You should not straight away go to treat asthma. If you go like that, you can miss the bus, and they invariably change the doctor. So you have to follow for certain time, and whether all these episodes are typically fitting to the viral infection, it doesn't need much treatment. You have to counsel the parents, and same time there are some structural causes like tracheomalacia or some congenital causes, comorbid. You have to rule out all these things, and for a practical thing, either you can follow, put the child as a preschool wheeze itself, or you can further classify into episodic viral wheeze and multi-trigger wheeze, and you can follow. Actually, in your prescription, most of us have a prescription. In the back side of the prescription, or in the right hand corner, or in the file, you can note down every episode what you think. Sometimes it may change from here to here, or ear to ear. So you have to follow this child. And at one point at time, if the child's cough and wheezing are recurrent, and you are convinced that it is not a very simple one, simple viral infection, place the child on therapeutic trial with ICS, and you can diagnose the asthma. I think I have given enough literature support and also how to make a diagnosis of asthma below 5 years and all. I think this is very important because in India is a country where the underdiagnosis, because most of the times cough and wheezing are treated by general practitioners. And I think anybody, even general practitioners also, once they happen to see this approach, they get convinced. We can very easily make a diagnosis of asthma after therapeutic trial and all. And once you make a diagnosis, these children will be uh, treated well, so that they may not go for airway remodeling and all. I think probably it might be a last slide. And thank you all. I am ready to answer all your questions. You can email me or you can put in the chat, so that during our next discussion, we'll discuss all these things. Thank you very much.